So it is my distinct pleasure to introduce probably two people who don't need introduction at this point in time, but we will certainly do so. So the first will be Dr. Wendy Davis, who is the Executive Director of Postpartum Support International, and Dr. Amandla Shabaka-Haynes, who is a resource and referral specialist for the Florida BH Impact Model. We'll start with Amandla, and then Wendy will present second. So Amandla, please.
Thank you so much, Tiffany, and thank you everyone for joining us today. I think this discussion is extremely important, and I really look forward to sharing with you all some of the things that BH Impact is doing in terms of equity. So as Tiffany said, I am the Resource and Referral Specialist, also the Program Manager for the BH Impact Program. You can go to the next slide. We are HRSA funded, but we also have a partnership with the Department of Health here in Florida, as well as the Florida Maternal Mental Health Collaborative. The main tenets of this program is to provide direct support to promote maternal and child health by building the capacity of healthcare providers who are addressing behavioral health with their patients. Next slide. These are our core components, and I'm really putting this out there so you all know what we are addressing just as on a foundation level. We provide community education and outreach, screening and screening supports, behavioral health training and support for obstetric clinicians, access through our psychiatric consultation service, and training for behavioral health providers and clinicians in the area. Next slide. So we're here to talk about equity and what are we doing to address that? I think it's really important, and it's something that the team here at BH Impact, we really feel like it's important. And it's really important to make the distinguish between the social determinants of health and the social determinants of equity. So I do want to run through that with you all for a couple of slides. Next slide, please. So how do we address this social determinants of health? I think we all kind of have a broad idea of what this is, but ACOG has come out with some emerging data that indicates disproportionate rates of COVID-19 infections, severe morbidity and mortality in some communities of color, particularly the Black, Latinx, and Native American communities. And they go on to say that these social determinants of health, also current and historic inequities in access to health care and other resources, as well as structural racism, contribute to these disparate outcomes. So ACOG knows this. You know, I think the community and the healthcare network as a whole has this understanding. But I think sometimes we don't really dig deeper into what are those social determinants. Dr. Kamara Jones, who is a leading researcher and expert on health equity and inequity, she kind of breaks down social determinants in this way: individual resources, hazards and toxic exposures, opportunity structures, and neighborhood or place-based, as well as community or group-based resources. Next slide. So now let's talk about the social determinants of equity. Those are the factors that determine the range of contexts observed in a given place and time, and the distribution of different populations into those different contexts. So here we're, within our work, we're addressing the perinatal, prenatal, and postpartum community. So what do those social determinants of equity include? Economic systems, which create class structure; racism, which structures opportunities and assigns value based on the social interpretation of how one looks; homophobia, sexism, and other isms that structure opportunities and assign value based on sexual orientation, gender, and other areas of difference from those in power. Next slide. So how do we address the social determinants of equity? I mentioned Dr. Kamara Jones. She has really done a lot of research on this. And she points out that in order to address the social determinants of equity, you also have to monitor for inequities along the axes of societal power. So in a sense, that is, in order to address these social determinants, we have to look at what are the power structures and monitor what happens in those structures. It also involves intervening and examining, like I said, the structures, the who, what, when, and where of decision-making, policies, the written how of decision-making, practices and norms, which are the unwritten how, and values, the why of decision-making. So when we address all of these things, that process is very important to eliminate, the health disparities that we know exist and to also achieve health equity. Next slide. And I put this picture here because I think it's a great illustration and really shows the difference between equality and equity. Here in the first side of the picture, we see three very different individuals, but they're receiving the same resources and they're still having very different outcomes. They're still not being able to see that ball game on the other side of the fence. At least one of them isn't. But on the equity side, we see these same very different individuals, but they're given different resources so that they all can achieve the same goal. So that's what we're trying to get to, equity. We're trying to determine who needs what to get to where they need to be. And in order to do that, we have to address the social determinants of health and equity. Next slide. So here's the meat of this particular presentation. Here at BH Impact, we spent a lot of time, kind of over the summer, identifying some actionable ways that we can make modifications to the operation of our program, as well as empower our healthcare community to address biases, health inequities, and systemic and structural racism. And we came up with 8 points, but we divided those 8 points into kind of two classifications, two categories. The first is core value action, and the other is practical action. These first 4 points under core value really reflect on how we address these things within ourselves, that internal reflection, that internal action, as well as within the team and our kind of smaller community that we work with on a regular basis. And those 4 points are: 1, address our own implicit bias and the role it plays in perpetuating disparities. Number 2, address the necessity of self-reflection in addressing disparities, especially regarding the role that privilege, bias, and microaggressions have in shaping the delivery of services. Number 3 is work as a team to identify power structures that create and maintain racial inequities within the domains that are in the scope of our project's purview. So we're doing those things that were set forth by Dr. Kamara Jones in terms of addressing social determinants of equity. And our 4th point is maintain a culturally sensitive and humble approach to providers and the patients that we serve. So those are our core value action points. Under our practical action points, we have include accurate and up-to-date information on health disparities in our trainings and technical assistance activities. Number 6 is include information and updates regarding equity in our materials, such as newsletters, websites, social media platforms, those avenues where we have direct contact with the community. The 7th point is continue to include accurate and updated information on providers of color in our mental health resource directories and how best to access those clinicians. And number 8 is maintain up-to-date knowledge of the validity of clinical and research assessments and the effectiveness of interventions on the underserved populations that we work with. Thank you. Next slide. So now that we've kind of gone over these 8 points of how we're going to address this, this slide talks about how we put this into practice, right? How are we addressing those things on a very practical level within our project? And the following 4 points are examples of how we're doing that. And this is just kind of a beginning point, because as we're growing and learning more, I'm sure there will be other things that will come up that we would like to put into practice as well. But here are 4 things that we're doing currently to address this. So the first thing is that our team members, we got Dr. Dyke Hansen, Dr. Baptiste, Melissa Newsom, and Dr. Heather Flynn, as well as Dr. Russo Swaras, who is our consulting psychiatrist. We're conducting ongoing reviews of emergent literature so that we can provide the most up-to-date strategies and statistics for addressing health disparities. That's a given. Number 2 is we're providing technical assistance activities with obstetric practices that are enrolled in our program, and providing them strategies on screening, assessing, and treating, also referring their perinatal patients more equitably. Number 3 is that we have formed many partnerships with community and state agencies and organizations that are invested in maternal and child health, i.e. the Maternal Child Health Collaborative that's here locally, the Florida Maternal Mental Health Collaborative, as well as the Florida Perinatal Quality Collaborative. And these partnerships enhance, or we're working together to enhance our statewide mental health provider database, so that we can have providers listed there of diverse backgrounds. And the 4th point is we're conducting qualitative interviews, which help us to explore the community needs and desires for behavioral health integration strategies. So as I mentioned, these are a few things that we are doing to address equity, keeping in mind that 8-point platform that I presented on before, and also knowing that these things are ongoing, they're modifiable. We will probably add to and enhance as we go along and learn. Next slide. Thank you. This is just quick reference list if anybody is interested. And thank you for hearing my presentation.
Amandla, thank you. I think this is really, really concrete, really actionable. I think something people really can, aspire to and model. I'm really tempted to just open it up for questions, but I want to, because I'm sure there's lots of questions and comments, but I'm going to, respect Wendy and her time. Let's have her present. And I think the 2 presentations together will really only enrich the discussion. So Wendy, if you want to go ahead, please. Thank you.
I do, but I do want to take a moment to just add my thanks and appreciation. I'm looking at Dr. Baptiste's beautiful smile, looking at you. You should be so proud, all of you. You just, it's a great program. And when we were working on our, leading up to this practice, I just learned so much just even in the practice, Amandla, and I just want to take the time to say that. Good job and well done. So I would say thank you, first of all, for inviting me to speak on behalf of Postpartum Support International, which is on the next slide, to talk about our efforts in addressing equity, inequity, to really do our part to be reflective and action oriented in addressing that. Am I seeing the right slide?
Yeah,
okay, awesome. That's great. Thank you. I know we were also blown away by that we kind of forgot to move the slide. So first of all, just to reintroduce you to PSI and our consultation line, I'm the executive director. Leanne Swanson is our executive administrator, and she's really the hub of coordinating the calls. And I always just want to acknowledge her amazing work in customer service, and that includes working with our consultants. And then Dr. Nicole Serino, who is here on Lifeline4Moms and is here today, who's our medical director. You can go to the next slide. And we really work together with the support and the nudging and the encouragement and the work of a board of directors and a growing staff, and it has become a priority, is long been a priority for PSI to address inequities. It's become even more of a focus priority and commitment now to really dig deeper and to say, how are we addressing diversity, equity, inclusion, and belonging, and access to care? So everything that that we've already heard from Dr. Shabaka-Haynes about how to address that really echoes the work that PSI has done, and our current kind of new board chair, Chris Rains, that many of you know, has a great desire to move from that value-based, right, approach to action, and also to create a true strategic plan to do so. Otherwise, how are we accountable? So we're really working and understanding that this, as we all know, right, we're all here because we want to improve access for care. That's kind of the point. And PSI has long been here to improve access to all families. But now when we move and to look at equity, diversity, racism, what does that really mean? And I really appreciate the language that you used, Dr. Shabaka-Haynes, and to really look at that ourselves. So I'm just going to walk you through a couple slides to say where we are now. And I want to first talk about our strategic plan. We created a 5-year strategic plan, and I'm pulling out actually the top 2 points of our strategic plan, which is one, reach more people who need help. But in that, in the subtext of that, is focused specifically on reaching people of color and LGBTQIA+ pregnant and postpartum and birthing people. Right. So this is specifically has to be not only a value, but it has to be an action, and then it has to be measurable, to the point that we heard before. And also this really to pull out in our strategic plan to how do we address, research, and advocate to remove insurance challenges and money as a barrier to care. The second point coming out of the strategic plan is incorporate PSI's values of diversity and inclusion at all levels. Again, moving from value to action. We understand now, and we will stand by this, that we must include people of color, men, LGBTQIA, also diverse religions and cultures, and dare I say, even right now, in politics. Everyone gets pregnant, everyone has babies, and we have to really be inclusive. At the same time, we are standing for Black Lives Matter and LGBTQIA and reproductive choice. So it's really, these are the kinds of things that we see all in our DEI efforts. So you can just see the language here is actually written into the plan now and to be measured. So focusing on the health and wellness of minoritized groups by building and stewarding partnerships with providers that represent and serve those populations. That's a big change for us, to be quite honest. It's not enough to say we value these. Now we are saying also we are these groups. And I appreciate also Jamie pointing that out. We talk about pregnant and birthing and parenting people, which includes adoptive parents as well as non-gestational. Okay, so that's the strategic plan. The last point on this slide is that we are aware, going back to the first column in your PowerPoint, Amandla, that DEI efforts have to start by doing our own work to reflect and improve awareness of our own implicit bias, our own gaps in knowledge and experience, our own reactions that we should work through, not on social media, but with each other. We do that as staff, we do that as board. And then to, as an organization, and this is true for any of us in the kind of entity you are, you might be 4 people and you might be a bigger organization like we are. We have a commitment to increase diversity in positions of influence and leadership and decision making. So on the next slide, I just have shared with you a couple of key actions that we're taking on the next slide, Dee. Thank you. And I'm happy to follow up and share links. So some of the equity initiatives in terms, for us, we are engaging as an organization in consultation. Thank you for introducing us to Change Matrix, Lifeline4Moms, because we are engaging with them to do a full consultation about not just, well, about our services and programs, our consultation line, our services on the helpline, our volunteers, our messaging, and all of that structure. We have already had some consultations. Some of you might know Dr. Saida Pepra from Diversity Uplifts. We've had a really, really great workshop with her for the board itself. And we are following up on that, both with our PSI faculty, national faculty, and with our volunteers and staff. We're investing money, time, energy, and resources into this work. It doesn't happen without it. Our training with Dr. Pepra was specifically about implicit bias and Black maternal mental health. All right, second is, as I said before, really increasing the diversity of our programs and our leadership there, including in trainings, which again, Dr. Shabaka-Haynes pointed that out, how important that is in trainings, because you're really disseminating and bringing up a new generation of providers. So we are also doing that, and certainly in our volunteers. And I didn't mention before, but our Spanish-speaking resources has been a long time investment of ours, and we're doing even more with that now. I wanted to share with you that we have a national online directory. Some of you are on it. We want you to utilize it as needed, but you can do a direct link there to PSI directory for providers of color. So there are 264, maybe more since I wrote the slide, providers of color on our directory just in the United States who have specialized training in perinatal mental health. And that's a great resource to use, and please help us fill it up. Fourth, our partnerships. We have a partnership with a Black Women's Health Imperative through our Mind the Gap initiative. And then a program within PSI that I will share the link in case you don't have it already is the Perinatal Mental Health Alliance for People of Color. I could talk about that for a long time. So let me just drop it there, and I'm happy to follow up. And then lastly, our future improvements, we want to increase the number of BIPOC consultants on our consulting line, as well as really do that same kind of reflection and work in making sure our consultants are aware of racial inequities, of LGBTQ, and that really everybody is up to speed. And secondly, to do more evaluation and listening meetings. Thank you, Dee, for putting in that link. And one of the things I want to say, you can just go to the next slide while I say this. One of the things that I learned, I just want to share this because it was so in the moment. Here we are, we're making these improvements, we're doing our inside work and our outside work. And when we're on the practice session, I just took advantage of the time and I said, we're struggling with how we collect data about race and ethnicity on our helpline. And I know a lot of the access programs have the same question. And it was really amazing, Dr. Shabaka-Haynes, because embedded into your program, as we just saw, what you shared just turned the key for me for our own programs. And it was simply that it's it's qualitative, to ask, what is your experience with perinatal resources and referrals and care so far, help seeker? And then also, when you get into that, you may ask later, how does race and ethnicity play a part in creating access? So the person, him or her or themselves, are bringing that information to you as part of your care of them. And that could be when you're talking to a provider or to a help seeker, as we call them in PSI. So I know you have an interview guide, and I learned a lot, and I just want to share that with folks. So last slide, that's the link to our consult line. That's the direct number. In case you don't know this, this is a new number. The old one still works, but we created a direct number to our consultation service that you see here. And that's it.
Thank you, Wendy. Thank you so much. I personally, I have been involved in some of these conversations with each of you at various points in time, and I continue to learn more and think deeper and think about what we need to do differently, and similar to what you were doing. And so I just want to open, I'd say, let's take the slides down, let's put on our cameras, let's pretend we're around a table, sharing a cup of coffee in our noontime tea or what have you, and just open it up for questions and conversations.
Well, I'll ask a question, Barbara Sheehy. Thank you both for your presentations. This is so helpful. And Dr. Shabaka-Haynes, if possible, I'd love to learn more about sort of your listening sessions with patients or the community. That's something that we're preparing to do in certain areas. And, I'd just sort of love to learn from your experience. And same with the technical assistance that you're providing to OBs in terms of addressing health disparities in that setting. I mean, it's great hearing about this, and then any actual tools you can share, it'd be terrific.
Yes, absolutely. And I'm happy to share anything with you. We're still kind of at the beginning of this process. In particular, the technical assistance piece, we're working with an OB practice that has done something really innovative for substance use screening. They've created their own screening, and they're in the process of getting it validated. So we're supporting them in validating their tool. And they've also, in connection with their screening, they've created a disparities dashboard within their EMR so that their residents can follow that dashboard in terms of their questioning, if there's a positive screen for substance use. So we're learning with them as to how that's going. We're researching as to how to validate their tool, and we're looking at how we can extract that disparities data, from them. And when we create, this kind of like model, this workflow, I'm pretty sure we'll be happy to share and talk more about that. And as far as the interviews, we're kind of at the beginning of that process. We've done about 5 interviews with clinicians at 2 of our enrolled practices. And the conversations have been very good. We've learned a lot about the types of questions, the language that we should use, defining certain terms. It's been very informative, and I'm sure Dr. Dyken-Hansen, once we analyze and listen to everything, we'll have some more to report out on that. So happy to do the interchange with you, Dr. Sheehy.
Thanks so much.
You're welcome.
I have a backwards question.
Oh,
I have a question for the group.
I was just going to come for you, Wendy.
You want to go first?
Sure.
Okay.
I would love to know how you all narrow down the providers of color in your directory.
Thank you.
How did you identify them?
Thank you. 2 ways. Great question. Anyone on the directory, first of all, has to have specific training in perinatal mental health. It doesn't have to be PSI, and they don't have to be a PSI member, but they have to have training. So we know all the trainings, or we research them. That can include sometimes for psychiatrist residency and fellowships. So I wanted to say that first. And then in particular, for the directory itself, we just try to disseminate the information over and over on social media and through our newsletters and through our partners chapters that the directory exists, and it's very easy. We don't add folks, they add themselves, right? So they go on, they're vetted, they're reviewed, and then we publish it. They can add anything they want about their practice. Within, like any good directory, within that there are categories of approach to services, gender identification, specialties. And one of the things that we have there as a category is I'm a provider of color. So they also note that, and then you can search for it. So that's how the directory in general works. The other part of that is working with our partners, specifically the Perinatal Mental Health Alliance for People of Color. We work in conjunction to send a lot of surveys and information out to gather information both about providers, mental health providers of color, healthcare, primary care, OBs, and also because we're PSI, volunteers and support groups who who are led by people of color. So it would be impossible to do if there was just one person working on it. But it's very possible to do with this infrastructure. And I'm so pleased to finally have that and to have the partnership with the Perinatal Mental Health Alliance and all of their partners. Is that what you wanted to know? Did I answer you okay?
Yes, you did. That's great. And it's kind of, we're on the same lines with the directory. So it's good to get that insight. Thank you.
Wendy, can you speak to if language is also one of those data points that you collect?
Yes. Oh my gosh, don't get me started, or
Okay.
do get me started. Because if anyone's ever been with me when I've done a tour of our directory, I get pretty excited. I think we're up to like 35 different languages and dialects. Of course, we have most experience and most resources in Spanish, but we also have many others. And it's just a matter of, again, having a hub and a place to collect. So we do ask about language. We also ask about gender. And that is really interesting to ask that about the providers, not just I serve folks, queer parents, or I serve LGBTQ, but I identify as a provider, as non-binary, for example. So helpful. You could go to do a geography search plus a category search. Okay, you did get me started, sorry, but you could say Massachusetts Spanish speaking or ASL.
Wonderful, wonderful. Other questions, comments? I mean, Amandla and Wendy are just such a tremendous resource in talking about in the whole PSI team and, Florida BH impact, not just Wendy and Amandla, there's other team members here. So we just open up the conversation and just take advantage of the opportunity.
Hi, my name is Rena Menke, and I am from the Michigan, the MC3 program at the University of Michigan. And I have a specific question about the Florida Impact Program. And so I am wondering if there's anything as you guys were implementing it that was surprising to you, that you were like, oh, I didn't expect this to happen. Like maybe as you were setting up the model, number of sessions that you were working with clients, types of referrals or questions that were coming through. Anything that you can think of that's like lessons learned that you wish you had known when you think back to the beginning when you started. And thank you. I'll mute myself and listen.
Wow. I'm going to invite my team to chime in here because I'm sure we can all comment on that. Man, challenges. I think our program is very community-based. We're not connected specifically to an academic health institution or an in-house health institution. So we've had to do a lot of work with our partners and with our collaborators, lots of collaborative efforts, to get this, especially the access piece going. So we're still maneuvering those collaborations. The Florida Maternal Mental Health Collaborative is actually one of our closest partners. Dr. Baptiste is the coordinator for that. And he's been great in terms of just kind of galvanizing everyone that showed some interest in being a part of the work groups, to really dig into the community, really strengthen those partnerships with, say, the Healthy Starts and, the the different organizations that are very instrumental here in the state. And that's been good because our access piece is kind of regionally focused. So we have three main regions that we focus on doing a lot of outreach and recruitment of practices. But through our partners, we've been able to reach a wider cross section of the community, as well as get those voices out, outside of clinical care. I think that's important. Did that answer your question? Anybody else from my team want to jump in on that?
Yeah, I would just pepper in that it is about making those connections, letting people know how you can benefit them, and also what resources you have available. Just continuing to promote that from the program. It's not like you're marketing, but you definitely want to make sure that it's well known what you bring to the table so that people have no problem in engaging the program and also being a part of it.
Adam and Amandla, I'm gonna, I think, push on that a little bit more. I've, ACOG, Amandla, you started by showing what sort of ACOG's definition is around social and structural determinants of health. And I've, recently had an opportunity to participate in process of reimagining prenatal care and bringing social determinants and structural determinants of health into that was an important part of the conversation. And I love the reframing around the determinants of equity, which I have to admit, I'd not previously heard that before. But one of the real sort of barriers to addressing this we've identified is that community to kind of healthcare connection. And you described yourself as being really community based. So this is a big question, and I welcome anyone jumping in on it, but like how, right? How do you really build that bridge between community and healthcare in a way that is really solid and almost seamless, so that it isn't one or the other, but it's together?
Mm-hmm. That's a great question.
Thank you.
Yeah. Hi, this is Heather. I'm not sure if you guys can hear me. Hi, Rena. It's Heather, your former colleague from Michigan. I wanted to I was going to make a similar point as Tiffany, and reiterate what Adam and Amandla were saying. I mean, these community connections, first of all, we've been building for years. And so this opportunity to build an access program was kind of built on a foundation of relationships. And we're talking stakeholders, really anybody who has a stake, Healthy Start, the health department, all the state agencies, other universities, advocates, survivors. And so we had this collaborative formed beforehand, but we only started in 2015. So it's certainly possible to build this. And then the other kind of key, I think, is really strengthening those bonds through ongoing communication. COVID, of course, has put a big damper on this because we used to do a lot of good in-person things, lunches, networking. We have an annual conference where we all are able to get together. But we are now trying to do more quarterly meetings where anybody can join. So keeping those relationships going, because there's so many, it doesn't take a village, it takes an entire state to really pull this off. And we need all hands on deck, and people are incredible in terms of volunteering to get involved. And we need all of our community partners. It's so vital. So thank you for asking that question.
Yeah, and I want to, I'm not sure if anybody else from any other teams has any response to that, but I also know Karen Burns has had her hand up, so I also want to turn it over to her.
Thanks. I had a question about gender inclusivity, since Wendy had referenced it. And one thing that we've talked about on our team is just around our language. And I'm really interested to hear what other people are doing or if they've made any adjustments. I think so much, before I came into maternal health, I was in intimate partner violence, and I did a lot of community training, and we always we talked a lot about using her and using like she, her pronouns when talking about the victim, and talking about, well, what does the data show? And then what does our language mean or communicate about that? And we've kind of come back around to having that conversation on our own team when we're talking about maternal health, mom's mental health. And anyway, I'm just curious if folks have thought about their language and pronouns from a gender inclusivity standpoint, if folks have made any adjustments, or I'm just really curious to hear what other states are doing around that.
Hi, Karen. And I'm sure Tiffany and Nancy could probably chime in more about this because they've helped us add those gender breakdown categories, I would say, to our tracker. We do utilize QuickBase to track our data, and we have recently expanded the gender field to have more categories so that we can accurately, collect that piece of data. And they were really helpful in terms of breaking down the terminology.
Mm-hmm. Yeah, I'm happy to share with, so I think, so a couple of things, I think, so it's interesting because our team has been thinking about Lifeline4Moms and also I'm on the American Psychiatric Association Women's Health Committee, and there's been conversations around how do we talk about, not making everything cisgendered, heteronormative, and wanting to have it be, inclusive. And, there's been, I'm sure folks you're all aware, there's been a big pendulum sort of swing towards not using the word woman because we don't want to be exclusive of, for example, a childbearing father, or of, someone who doesn't identify as a male or a female, so who's non-binary, for example. And so there's been, we've been thinking about this as we're writing papers and everything. And, so a lot of times, a lot of people are using the term perinatal individuals. So we're just kind of not using the word woman because that's not necessarily going to include everybody. And it's interesting because on the APA committee, there's an individual who is who's male, assigned female at birth, and is an expert in this area. And his perspective on it is very interesting. He basically says, I've spent 30 years as a woman, I've spent 20 years as a man. And he says, that, his experience is, and just his feeling, as being an expert in this area, in addition to his own lived experience, that we really need to be careful not to take the woman out of it, because women themselves have been a population that's been marginalized, and as people, and gender itself can be something that people can be marginalized based on how based on their appearance and so forth, how they identify. And so what the conversation has been, well, do we use the term, like we just submitted a position statement that got approved, and it was, the term used was women and other perinatal individuals. So you're still keeping the woman in it, but using that. It's a clunky term. It's a lot of words. So when we write papers, people are like, why using it? So it's really, I think there's a lot being done around this. And I think there's a lot of conversations around it. But, so clearly we need to be inclusive. It's this perspective on not just taking the woman out, because, and the point he made was, when we think about, for example, like a chairman, it might be a woman, but they call a chairman, like, it's like, it's kind of taking that. So don't necessarily have an answer, but kind of more sharing what some of these conversations have been. And that's what our team has really landed on, is trying to use the term perinatal women and other, and other perinatal individuals, or using terms like that. So, and I just wanted to also add a comment about the tracking. So we, and Gina Kelleher may want to share a bit about this. We just went through this huge process, and it felt like a very complicated process, because you alluded to, or explicitly said, Wendy, about adding race and ethnicity when people call, because from our perspective, we don't know the race or ethnicity of the individuals we were serving. We really didn't know. So we added it in. Gina has been leading this process as part of our equity subgroup, and you may want to share a little bit about it, Gina, but we did add that in recently, and happy to maybe, Gina, you may want to, because it is complicated though, but we added in when people called. Do you want to share a little bit about that, Gina? Because Wendy had talked about it earlier.
Sure. So that was one of our goals, is, we don't know what we don't know. So we just started very simply saying, we're going to ask anyone who calls in for services to not only give the usual demographic information and the gestational age and things like that, but also what is the patient's self-reported race and ethnicity. And we actually worked with a consultant to come up with the script We were very mindful about it so that we're all asking it the same way. And we also came up with a script for if there's any pushback or questions, why are we doing this? And just really being mindful about letting also the people that seek our services know that we're going to be doing this. So we developed a script for our 800 line, our 855 line, to let people know when you're calling in, please leave this information. We shared it in a newsletter, and we're in the process of sharing it on our website. And from that, we're going to wait a few months, but we're going to see from that, like, where we need to work or where we need to really focus our efforts.
Thank you, Gina, for sharing that. Yeah, and our it's kind of like if you're not measuring it, it's hard to improve it. So we wanted to, so that's what we've added. Thank you, Gina, for sharing and for leading that process. And I think there's some questions from Amandla again. So
yeah, I was going to say there's from Calandra Park. I don't know if you want to unmute yourself, or I can read the chat, but a question for Amandla. So it's as if there was generally a positive, inquiring if there was a curiosity around if there was generally a positive response to the project, were people engaged, any recommendations or tips for galvanizing a community around health equity, especially in communities where there's not a lot of racial diversity.
All right, okay. Thank you for that question. And again, I'm going to invite my team to jump in here at any point. Calandra, were you talking specifically about the collaborative piece, or were you talking about the qualitative interviews?
Her mic is not working. All of the above, everything.
Okay. Sorry. Let me just go back. And I don't know if Dr. Dyken-Hansen is on, but I think Dr. Baptiste and Melissa might be able to help with this. As far as the qualitative interviews, the majority of folks that we've reached out to in our participating practices were actually very happy to participate. And readily agreed to, schedule a time to engage in the interview. Dr. Dyken-Hansen did a great job with structuring an interview guide with protocols, leading questions and probing questions, making sure that, we're getting the conversation, we're getting that thought process along the lines that we want. So that's been pretty good. For our collaborative efforts with the Maternal Mental Health Collaborative, I mentioned today we had our first work group meeting after the conference. That was the last work group meeting, but it was an excellent response. It was kind of an open invitation to participate, but there were quite a few participants, very lively discussion. This topic of equity definitely was emerging, and so many kind of, I won't say side initiatives, but really focused thoughts on what to do next and how we can work together and how we can also work within our individual agencies to push the agendas forward that we're identifying.
Can I ask a sort of a related question, which is when you developed your 8 points platform, like who was involved in that, and what was sort of the actual process? And Wendy, this question is relevant to you and your board and what you chose to focus on. So like, who did you bring to the table around developing those?
Wendy?
You want to take turns here. So, excellent question, of course, because that is part of improving racial and class and leadership inequities, right? Is who is part of this process. And for us, very specifically, yes, that includes our board, because we want to, first, we also want to make sure that the kind of the strategic plan and our policies are also aligned, that I could go off and do a workshop, but that doesn't matter if my policies and my board is not with me, or if you have one person on your committee who's like, wait, now what? What about all lives? But we don't, we have to really talk about that and lock it in. Secondly, who is part of gathering that information for us? Our go-to resource really, when we're developing things for people of color, we go to the Perinatal Mental Health Alliance for People of Color, and we talk to them all the time. Like frequently, we have standing meetings, we talk it out. If we're developing things for Spanish-speaking families, we go to our Spanish-speaking volunteers, et cetera, LGBTQ. And there's a thing I want to say about that before I pass it back to you, Amandla, is that when you put yourself out there as wanting to improve services, you do have to be ready for the input, and how important it is at the core of this for us to remember that it's most important that we are responsive, not that we are right. And once you involve yourself in the community listening and in the surveys and the interviews, all of our improvements have been in some ways as a result of criticism. And we have to be able to be really open to that. And now it just feels like part of how we grow. And not to feel like when you have that community forum or the face, that you have to defend anything, why you didn't do it before, the mistakes you've made. And that's been a real wonderful part of growth for me, I would say, and difficult, but good. So Amandla, back to you. Who do you involve in developing these great, the 8-point thing, for example? I'm interested in that too.
Before she reads that, I do want to, like, something that comes to my mind that I'd like to share is that in doing this type of work, when you want to involve people in the process of creating an environment of equity, you have to get comfortable with being uncomfortable. This is not quote unquote easy work. It's not work that you should expect everybody's just going to want to do it or feel good about doing it or want to join in the conversation. You have to know that people are going to be resistant. People, because they have to deal with their biases. They have to deal with them themselves. And it's for each one of us as individuals to do that work on ourselves, with ourselves, and then come to a group, into a collective, get some more perspective, get some feedback, and be okay with not being okay. Be okay with not being correct or right on a particular topic, because this is the hard work that must be done. So I just wanted to share that because I think
Thank you. Goodness, thank you so much for that.
Thank you.
Thank you, Adam, Dr. Baptiste, and Wendy too. I love what we're talking about is, right, this growth mindset is sort of, learning from our criticisms, being open to the discomfort, sitting with that and letting that, better who we are as individuals and as a group. Amandla, you were.
Yeah, and I was just going to say, as far as what and who informed that 8-point plan, we had a small team over the summer when this happened, but I will say that many of us on the team, we have experience working through addressing implicit bias, undoing that systemic racism. Dr. Deckenhausen has a PhD who, built her dissertation around racism. So the experience was there. We are in an academic research institution. So, we have the tools to get information. And I think it was just kind of like the perfect storm and timing for us as that small team at that time to kind of pull on our experiences. And we drafted this, and Lifeline4Moms, or MCPAP, had a really good model for us to follow. I think they released something similar, like a letter stating their commitment to doing this work. So we kind of, picked up the mantle and did something similar, of course, making it specific to our project and the services that we're trying to provide.
I want to add to that, because you're giving an example of something I've been thinking about this whole hour, which is a lot of what we've learned has been from a lot of your programs, quite honestly. And when I think like my own learning and my foundational documents, like foundational learning. For example, I go back to the Michigan team, that you've for years, looked at trauma-informed care, racial inequities, and how to reach moms, for an example. Many of you all, I want to acknowledge that we just got asked to speak because we got asked to speak, but you all have informed us. And it's been really important for PSI, as we learned from you, that that's what we build on. So I want to thank you and Lifeline4Moms for kind of providing this opportunity to be together in one forum.
I was going to say that's probably the perfect note to end on. Have Josephine bring up the evaluation slide. First of all, thank you, Dr. Shabaka-Haynes. Thank you, Dr. Davis. Thank you for inspiring the conversation and for, forewarning, and thank you to the programs who will speak in the future, because that is exactly what this is about. The network is about, is to learn from each other, because we are all doing things and we just need to be aware of them from each other that are models, for what others should be doing. And so, thank you for sharing what you're doing on equity today, and we look forward to hearing from everybody else on future topics, and we will continue to tap shoulders. And again, we are also very open to topics. If there's something you're doing that you want to share, please let us know, because that's what this environment is for. So thank you so very much. And thank you again, Wendy and Amandla, for very concrete steps. I think we all want to do the right thing, but knowing how to do that is where some programs are struggling, right? So thank you.